So it's my pleasure to introduce Dr. ASHRITH GUHA, who is one of my partners and is a specialist in heart transplant mechanical circulatory support, as well as pulmonary hypertension. And that's what he's going to talk to us about today.
Thank you, Huie. Well, good afternoon again. So we'll end today's, at least this part of the symposium with the heart transplant mechanical circulatory support talk. So, all right, these are my disclosures. So the objectives for this talk are to identify end-stage disease and to identify which patients you should be referring to a heart transplant program. Looking at some contraindications and considerations in this special population, and also looking at whom we should be considering, single organ versus multi-organ transplantation, and some risk prediction models after transplantation to predict, poor outcomes in this population. And there's very little data in durable MCS in adult congenital heart disease, so we'll take a look at that as well. So we'll start off with a patient. This is a 51-year-old lady with Eisenmenger's due to a large secondum ASD. She came to us on 3-drug regimen, macitentan, tadalafil, and selexipag, with really ambulatory class 4 symptoms and worsening functional class in the last 6 months with systemic oxygen saturations in the 60%. On 3-drug regimen. She's had 3 hospitalizations. She's had 1 episode of hemoptysis. And her GFR is around 50 ml per minute per meter square. She got here, we did a right heart cath, showing, again, predominantly right-sided heart failure symptoms, right atrial pressure of 22 with a QP of 2.5 liters per minute, and a PA, despite being on triple therapy, PA mean of 42 with a left upper pulmonary vein pressure of 15, gives her a PVR of 9 Woods units. So, this patient sort of goes on to demonstrates a lot of things which we'll go over in this slide, where, she's had 2 repeated hospitalizations for heart failure in the past year, progressive deterioration in renal function and in functional class. She's really sort of intolerant to a lot of other medical therapy, and she's not able to walk a block. So these are all the features of somebody who has really advanced heart failure, and you should be considering, transplantation or something more in these patients. So this is very generic for any patient with heart failure, but when it comes to patients with adult congenital heart disease, so I want to, go over a few things. Now, patients with adult congenital heart disease who've had a near sudden death event or life-threatening arrhythmias, should be considered for heart transplantation. The same with patients who have really stage C heart failure, which means they're able to, maybe do their daily activities of living, but have reactive pulmonary hypertension, which means it's not fixed, and you want to catch them before then, because unlike our patient, truly has reactive pulmonary hypertension, in which case you're really looking at a dual organ transplantation. And again, in FONTAN patients, like Dr. Johnson said here, patients with protein-losing enteropathy and plastic bronchitis which are refractory to medical therapy should be evaluated by a heart transplant center. And progressive cyanosis, like we saw in our patient, leading to functional decline, should be evaluated by a heart transplant program. So once you have a patient who's has heart failure, so what do you do next? Try to see if they, if there is any reversible condition for their worsening symptoms. So in our patient, we try to see, what else we could do medically to get them better. Now, a lot of our patients, especially the ones who have these collaterals, Dr. Lin goes in here, looks to see if the collaterals provide, causing a lot of high output kind of physiology, and, whether coiling them would help sometimes. And, and if there is a percutaneous or surgical intervention, especially in patients who have, leaky pulmonic valves, if a surgical intervention or percutaneous intervention would be helpful. If none of those are an option, then you're really looking at transplantation. So what did we do with our patient? We switched her to Velitri because she was on triple oral regimen. We switched her to Velitri and quickly up-titrated within about 2-3 weeks to 15 nanograms per kilo per minute, which is a reasonable dose for somebody who's almost IV prostacyclin naive, and with minimal improvement in symptoms, and hypoxia pretty much remained the same. And what we did notice was with Velitri, she was having worsening renal function because her SVR went down, but her RA pressure pretty much remained the same. So her perfusion pressure across the kidneys, kind of fell and caused her creatinine to go up. So then we started around, inotropes with marked improvement in her creatinine, and we listed her for heart-lung transplantation in this case, mainly because of her fixed PVR and a large secondary ASD. So what are the contraindications? Because you want to catch them before some of these contraindications occur. And some of the contraindications are really associated with other life-limiting conditions, such as cancer, AIDS, active lupus, or multisystem amyloid. But in patients with adult congenital heart disease, occasionally complex anatomy, especially if it's combined with additional contraindications, they become really challenging, and we'll sort of go over why it become challenging. And again, multiple severe congenital anomalies and severe metabolic disease, which is associated with adult congenital heart disease. And some patients, especially with Downs, who have a lot of neurocognitive impairment, they are sometimes a contraindication to transplantation. So, I just want to switch gears here and talk a little bit about the new allocation criteria, and which is going to come probably late spring or early summer of next year. And as you can see here, they have tried to make some room for patients with adult congenital heart disease, but in this whole 1, 2, 3, you really don't see adult congenital heart disease at all. And they're actually, now in status 4. So I think overall it's probably a disservice to them because a lot of them are sick, and I think this guidelines really sort of heavily geared towards patients who have mechanical circulatory support. So I think what we'll end up seeing in the next few years as we wait is a lot more usage of mechanical circulatory support in adult congenital patients, especially the ones with the failing systemic ventricle and things like that, to get them to transplantation. So again, how do these patients do after transplantation? And as you can see here, this is a graph comparing patients who've had congenital heart disease and no congenital heart disease. And 1 year survival is definitely limited. It's under 80% compared to now almost 91% for all other patients. So these patients don't do as well compared to patients who do not have congenital heart disease. And again, the risk factors remain the same for both of them, mechanical ventilation, being in the ICU, donor age. These honestly are not too different. One thing that I found really interesting is that centers which transplant them and do not perform pediatric transplants or do not have the experience to do pediatric transplants, they don't do as well. So that was definitely an interesting finding. Now, I just wanted to kind of delve into why we see this difference. And I think a lot of this is actually being driven by the FONTAN population. Because if you look at the non-FONTAN group, their 1 year survival is pretty close to patients with no adult congenital disease. And this is a meta-analysis on the left. And as you can see, 1 year survival, with the meta-analysis 80%, but you can see that the distribution's all over from like 65% to 80, some centers with 100%, but only 6 to 8 transplants. So I think the FONTAN patients really weigh down on this whole population in moving their mortality kind of downward. And this is a very again complex topic, mainly because of the involvement of other organs. And like Dr. Johnson mentioned, it's very difficult to really decide whether to go with just heart alone or heart liver. There is a lot of variability depending on center to center. And I think there has been some data with regard to having significant portal hypertension, again documented by portal pressure measurements and liver biopsy showing advanced cirrhosis, and presence of HCC or MELD greater than 18 favoring a dual organ transplant, and patients with mild portal hypertension with good synthetic liver function that you could probably just do with heart alone. But again, I think these should be really undertaken in centers who've had some experience with operating on adult congenital heart disease patients. Now, switching gears to MCS and adult congenital heart disease, there is very little data. There's a lot of data in pediatric population, but in adult congenital heart disease, very, very little data. There is one meta-analysis of 12 centers with 65 patients in the whole meta-analysis. And it's, I think, though it is increasing, I think we take care of at least 2 patients who've had their VADs in the systemic, RV in a congenitally corrected transposition, again, listed for transplantation. But there's a lot of data with, ECMO in patients presenting with cardiogenic shock or refractory arrhythmias. But durable VADs, I think they're increasing, but so far the data is very limited. And most of the VADs are used as bridge to transplantation. At least in the early data, they do not seem to provide much survival advantage on the waiting list, just because of the, I think, the low flow in the pulmonary circuit, especially if you put it on the right side, and just the complication rates of VADs in these patients, I think. And one thing we have to recognize is a lot of these patients are very sensitized. So getting them to transplant as it is hard, and you put in a VAD, I think is just going to get harder. So this is from that meta-analysis, which shows that actually, again, as you see on the graph on the right, that the intermax category has been going down, which means the patient, patients are getting VADs kind of sooner, and people are not waiting till they get sicker, which is a national trend even with patients with just heart failure alone. And the commercially available HeartMate 2 and HeartWare seem to be the most common. Again, HeartWare probably a little more, just because it's a pericardial pump and probably easier to transplant, especially if they are put in through the thoracic route, since a lot of these patients have already had multiple sternotomies. Again, like I was saying, a lot of these patients, we are seeing more patients with destination therapy with these durable MCS. Now, coming back to our patient, so this patient actually got transplanted this morning. She's actually doing well and now in the ICU. She was only listed for a week here. So I just wanted to plug in our Methodist heart transplant program here. It's led by Dr. MacGillivray and Dr. Bruckner and Dr. Estep. We are one of the largest multi-organ programs in the country. I think in the last few years, we've probably been like number 2 in the country with excellent results with multi-organs. We do about 45, 50 heart transplants and 60 VADs. So if you guys have any patients who, that you guys can't transplant elsewhere, especially on the East Coast, we do transplant a lot of heart livers from Colombia. So just to plug in. All right, so again, to conclude, early identification of end-stage disease using functional assessment and other characteristics can lead to early referral. Early referral can potentially decrease need for dual organ transplantation. Again, role of MCS is growing, especially as the adult congenital heart disease patients increase in number and donor shortage continues. So, well, thank you very much, and happy to take any questions.